Thank you. Thank you, Mr. Chairman. So, if I'm speaking too fast for the translator, please say hello. That's fine. Greek language is really difficult to understand when you don't speak at all. And I got difficulties to get the messages you gave before. But anyway. So now we move to another organ, which is, for me at least, one of the most important and not so easy to understand. So we'll spend maybe not enough time because it's a complex issue. What we know very well is we have a lot of acute kidney injury in our ICU patients. That is well known for many years. I'm sure that most of you are convinced that the acute kidney injury is essentially related to hypoperfusion of the kidney. Who is convinced about that? Raise your hand. 1, 2, come on. 3, 4, 5, 6, and the others are convinced about what? You are convinced that the kidney is never hypoperfused? I'm surprised. So usually what you teach to the residents is to say, my good friend, you should give fluid pressure, blah, blah, because it's not peeing anymore, and we need a better perfusion for the kidney. And Manu said quite interesting things in his lecture about the fluid and all the stuff like this. So hypoperfusion might be an issue, okay. And the other one is something which is becoming more and more complex and probably more realistic, is that the hypoperfusion is not the key issue for the acute kidney injury. It participates in, but not too much, and it's more related to circulating inflammation mediators, cells, which are coming to the tissues, especially the kidney, and then destroying or putting the cells, the kidney cells, in a bad shape. And that's something that we would like to demonstrate soon, because this is, of course, depending of the comorbidity you have, is depending of the genetics or your genome you have. It doesn't work anymore. And you have a lot of interactions between these issues. And in addition to that, what we do in the ICU all the time, we are dealing with the so-called extra-renal factors, which are always doing something on the renal function or the kidney is responding to. And you know very well that when you have, of course, the autonomic nervous system is directly linked from the brain to the kidney by the reflexes. When you do, for example, positive pressure breathing, you see for all patients the diuresis goes down. Why? It's not a hemodynamic issue, it's a reflex coming from this autonomic nervous system. Then having this modification, you see you have all these hormones which are really concerned because they are released and circulating, but have some effect on the renal function, renal perfusion, renal blood flow distribution. And we play with this all the time. And we don't know well, but this is true. So you have other interactions, organ to the kidney. And you know very well the role of the liver on the kidney function. So you have the hepatorenal syndrome, for example, that you know very well, which is interacting with the kidney. The kidney is still good. I mean, it can work very well. If you change the environment, it works well. But if you stay in this liver failure, the kidney doesn't work, which means that the functional capabilities of the kidney is extremely high depending on the stimulation you put around. And that's a very important issue to define, something that you know very well, which is a so-called pre-renal azotemia, which is extremely difficult to diagnose. Do you think it's easy to say, oh, this is a functional failure, renal failure? We say that all the time at the bedside. Oh, my good friend, it's probably functional formula. Formula of what? Formula of the urine. You look at the sodium. If the sodium is low and the potassium is high, oh, you say this is a functional renal failure, which is absolutely not true and not demonstrated at all. So, the other issue which is very important to remember is the kidney is the organ which is consuming the most the oxygen per gram of tissue. This is the most expensive organ you have. More than the ladies you can marry. Which means a lot. You agree? Because you have to pay all the time for this organ as you pay for your wife. You pay because the kidney works 24 hours a day. It's not popular in France, as you know. We don't like to work more than 7 hours per day. But the kidney works all the time. Filtrating, reabsorbing, having, for example, 42,000 sodium filtered, and you pee only 100 per day. Or 200. Which means that you work a lot to keep the sodium and the water in your body, and that's the kidney who does the job. And to do it, it needs some energy to be spent at different levels. So you have active pumps on the different part of the tubules, and these pumps needs energy to function normally. And this energy increases the oxygen consumption. The oxygen consumption is elevated, so that means you should pay the banker. If you spend a lot of money for many things you should pay for. In addition to that, you are, for this oxygen consumption, influenced by the extrarenal factors, which are really important to consider, and then the blood flow has to be sufficient to cover the oxygen consumption. This is a key point. So finally you can say perfusion, I don't know, but at least renal oxygenation more than the perfusion itself might be the issue because of this oxygen consumption, which is extremely constantly important. Then you have the normal structure, and Mathieu did a very nice review on this. Ischemia reperfusion. You see the tubules, you see the endothelial cells, you see the blood and the red cells and the white cells. Normally it flows easily. But when you have ischemia reperfusion, inflammation, trauma, pancreatitis, whatever, you have in the vessels some activated cells with always the same thing. You have abnormal endothelial cells, the white cells are activated, you get the platelets, they cross over. And then you have, in addition to that, very closely, the renal tubular cells are becoming abnormal. And you get some necrotic epithelial cells, you get apoptotic cells, and you get a lot of tissue lesions together, which participates in the renal dysfunction, which might be originating in the vessels and targeting the tubules. That's very important to remember that. So finally, do we speak about something which is important? Yes, in terms of epidemiology, this classic work for 2005 in the JAMA, you'll see among these patients they looked at, you see 60% of the patients having a renal failure, 70% of them were essentially septic or sepsis syndrome, and only 51% got non-septic inflammation. And the sepsis is the first cause of acute renal failure in the ICU. Okay. What are the factors which are associated with this? You can see, of course, septic shock, the major surgery you do, especially the vascular surgery, the cardiogenic shock and hypovolemia are the most important factors responsible for acute kidney injury. Then the people were really concerned about the definition. So you know that until recently we had more than 30 definitions of acute renal failure. 30. And they decided to do a common assessment of renal dysfunction. And finally, when we look at the creatinine or the urinary output, this is the end of the dysfunction. So you get global organ dysfunction. But the idea is to get something which is helping you to diagnose earlier cells or tissue damage before having abnormal organ function. Then you can expect to do something efficiently for the patients to be treated. And that's the reason why they decided to develop this scoring system, which is the refill system, where the risk, the injury, the failure, the loss. You have this in the website everywhere that I'm sure you know very well. So there is another one which is popular too, and that's the one we use preferentially, is the Keen scoring system, which is simpler, but say with the same goal and roughly the same parameters, and it works well. And recently it has been published that the SOFA, the kidney SOFA scale, is working as the Keen to define the patients very well. So you need a scoring system to know what do you speak about. So we conducted a trial in septic shock patients in a multicentric intensive care units, medical, surgical, with cancer, no cancer, etc. Among these patients, finally 175 were selected for acute kidney injury epidemiology, and we found that 140 got acute kidney injury and only 40 didn't, which means that roughly 2/3 of the patients in septic shock have a kidney injury, which is a huge amount. Among these 2/3, you get 50% with severe acute kidney injury, which means renal replacement therapy, and the others were kept without renal replacement therapy, and we classify this as a moderate acute kidney injury. So the question was, probably the acute kidney injury might be related to the intensity of shock treatment you give. The more you can suspect that giving more norepinephrine may have some bad consequences to the kidney. Here you have the vasoactive index given in the absence of acute, mild acute kidney injury or severe acute kidney injury. There was no clear difference in average. So clearly in this population, the incidence of drugs for shock resuscitation does not play a major role. A second issue, which is not published yet, that's submitted to the publication, is there any acute kidney injury and septic shock which is occurring later on the first 2 days? Or do you have some patients failing after 2 days? No, it seems to be fixed. I was surprised to see that. Here you have no absent, moderate or high kidney injury, and then the patient who got this in the first 2 days will keep this for the rest of the first week and then improve after that. And the patient who will not get it in the first 2 days will never get it, except for one patient. So that's amazing to see that it's initially that you fix the prognosis for the outcome for the kidney, you will or will not have acute kidney injury. Is there any relation between the severity of the acute kidney injury and the mortality rate? This is made taking into account the confounding factors using the so-called competitive risk analysis. And you'll see that only the people with severe acute kidney injury have a worse prognosis compared to the mild kidney injury or absence of kidney injury in septic shock. But look at the effectiveness of this. 4 times more death rate than without acute kidney injury. There's a huge relationship between the two. There is no mechanistic issues between the two, but they are associated statistically. So if you do the independent study for odds ratio, you see again always no acute kidney injury or moderate kidney injury versus severe, and clearly it's largely significantly different for association to death rate. So having a severe acute kidney injury is associated with a higher rate of death. Why? We don't know. That's something that we can discuss. Is there related to the extrarenal factors I mentioned initially, intensity of mechanical ventilation, drug you give, or sympathetic stimulation, intensity of sedation, reflexes, etc.? We don't know. Many years ago in anesthesiology journal, we have looked at this issue from zip to PEEP, and we measured the urinary output and the sodium expression you reduce about 50% the urinary output when just you apply the PEEP. Then the sodium excretion was reduced also statistically significantly. It's true everywhere. Even in the OR, you go, you put a positive pressure breathing, you get oliguria. Every patient. So GFR was not modified, and the osmolar clearance was reduced. So you have problem to eliminate the water. If you look at the hormonal consequences, the vasopressin or ADH, you see it does not change from ZIP to PEEP. So you don't activate the ADH release by the PEEP application, but you double the plasma renin activity, you increase the norepinephrine level, and epinephrine was trending to increase, but this was not significant. So you get some hormonal reflexes which are activated by positive pressure breathing. That might play a role. And norepinephrine variation from ZIP to PEEP is associated with the plasma renin activity. That means that the reflexes are working. What's going on for the renal blood flow and the cardiac index? You don't have a lot of data in human beings. You see the cardiac index, you see the renal blood flow. They are very well correlated. So you can imagine that the more you give fluid to resuscitate the patients, you increase the cardiac output, but you increase the renal blood flow. And this is the only one situation where you have a kidney failure with hyperdynamic state, hyperdynamic renal blood flow. So what's up about the hypoperfusion? Everybody says maybe it plays an important role, and that may explain why you have pre-renal azotemia. If it's not treated rapidly, you move to a real kidney injury. The pre-renal azotemia corresponds to the response to perirenal factors with no renal tissue injury. That's the definition. Then we can call this perirenal azotemia and not pre-renal azotemia. Perirenal azotemia. This will be published in the Control Nephrology. You get a special issue about the roundtable which has been held in Brussels in March, last March. Renal injury can occur if the action of the perirenal factors persist or are more important. And now the people said if you still stimulate the perirenal factors for more than 2 days and you still have abnormal urine, that means you get kidney injury. And the kidney is a marker of systemic disease until renal tissue is damaged. And the systemic inflammation is changing renal response to perirenal factors. And that's a key point to know what's going on for the venous congestion, for the renal venous congestion that we don't know yet. So the question might be, I would like to increase the blood pressure. And you do that every day. You give norepinephrine to improve the blood pressure because you say the kidney has to be better perfused. We need a perfusion pressure. That's it. Maybe you are wrong. Maybe it doesn't work. That's fine for some other issues, but not for the kidney. This is a very nice work done by Mathieu when he was working in the Janis's lab, and we did this protocol targeting different blood pressure, 80 or 40, low and high, with different fluids, saline or hypertonic saline or blood. And then we'll look at the effectiveness of this. You see the hemorrhage, and you see the blood flow is going down. Then you give the resuscitation with the fluid. You don't change the oxygen delivery. Whatever you target the pressure at 80 or 40. Whatever the pressure you target, you give the fluid. There is no change for the oxygen delivery to the tissue. The only one which was efficient is the transfusion of red cells. In other words, renal blood flow, in terms of flow, does not make sense if the flow does not contain oxygen carrier. When we speak about blood flow, we should speak about blood oxygen delivery. And the blood flow in itself doesn't make sense. Giving fluid just to get a flow doesn't make sense because you don't give oxygen to the tissues. And that's a key point. So the people concluded that what is this article tells us that is new in rats with hemorrhagic shock, correcting mean arterial pressure of 80 millimeters of mercury with normal hypertonic saline did not increase renal oxygenation more than 40 millimeters of mercury. Rapidly correcting arterial pressure in shock may not guarantee providing sufficient oxygen to the kidneys. And we give tons of fluids, crystalloids and colloids and all the stuff like this. Not sure it's reasonable to continue like this. Yeah, but the blood pressure is important to be maintained. Come on, you are provocating Didier. I don't trust you too much. Blah, blah, blah. I know that all the time. But this paper is nice. You see, 65, 85 endpoint for blood pressure in human beings with septic shock. If you look at this and you look at the urine flow, 4 hours, 8 hours, 4 hours, 8 hours, 65, 85, exactly the same. So it seems to be independent of the blood pressure. Yeah, but look at the creatinine. Creatinine, exactly the same. High or low pressure. But look at the clearance, exactly the same. So having 80 or 65 is exactly the same for the kidney. So the blood pressure is not an issue. So we have in our center very special emergencies, which are the postpartum hemorrhage. So pure hemorrhage. The ladies are young and very healthy, and they are bleeding after the delivery a lot. It's an emergency. So it's a pure loss of blood. So we expected to have, with hypoperfusion, a lot of renal injury, if it's hypoperfusion dependent. You see the blood pressure was well maintained, I don't know, here with 2 or more than 2 red blood cells transfusion. You see the systolic blood pressure and the creatinine was absolutely independent, so the blood pressure was well maintained. So what happens for the creatinine? The more you transfuse 4 red blood cells, the more is the creatinine level. So in this particular case, hypoperfusion and shock with the loss of red cells is an issue. You have to transfuse more. Let's go to the volume. You remember this classic paper for the ARDS network saying that there is a liberal strategy versus a conservative strategy. You expect with the liberal you get more fluid, more flow, and more preserved renal function. And look at the renal failure. Exactly the same whatever you do. So finally, the fluid you give is not an issue. Then, what we know is the more you give fluid, the more you kill the patient, or at least the more the death rate is associated with. The people getting a huge amount of fluid are dying more. Probably because they are more severe, but maybe the fluid may play a role in itself. I don't have the time to go through. So if it's not the perfusion itself or the oxygenation, it might be detectable on the biopsies. If you have ischemia in the kidney, you should have biopsies with ischemic lesions. That's a glomerular rate. You don't have ischemia here. You have just infiltration by white cells, inflammatory cells, but no ischemia. Say, okay, but the glomerular space is not a good one. You should go to the tubules. But you don't have in the tubules not too many necrotic cells, so the acute tubular necrosis in acute inflammation does not exist in human beings. So this is to be redone totally. But you get a lot of apoptotic cells on the tubules, so you induce the apoptosis, and that's a key issue, which is not ischemia. I'm just finishing, I promise you. So if you don't have this ischemic lesions, you can say that you have essential lesions related to leukocytic infiltration and apoptosis. This has nothing to do with perfusion and ischemia. Nothing to do with this. So finally, immune toxicity for the renal tissue is the key problem for the next years. And this has been nicely summarized in many cartoons, which are finally similar to many others. You get the vessels, you get the cells, you get endothelial cells, activated white cells, crossing over, adhering and doing the job. And we look at this, but I don't have the time to go through. Do you have a constitution in your genes which is able to tell you before anything else that you will have in the same conditions an acute renal failure or not? And we found 2 genes which are really well associated with the occurrence of acute kidney injury, severe acute kidney injury, necessitating renal replacement therapy or not. And that's the important issue for the future. Thank you very much for your attention.